Hello, MedTech Insight enthusiasts. This is Dr. Jennifer Joe with my co-host, the fabulous Dr. Ami Bhatt, Chief Innovation Officer of the American College of Cardiology. During each show, we talk with a guest about the latest in innovation in digital health, biotech, and healthcare, with the clinician focus on technologies that we think will be game changers. All shows are live and recorded. You can find the old shows by following me on LinkedIn at Jennifer Joe MD or on YouTube under Vanguard.Health. MedTech Insights is live and interactive, and we like hearing from our audience. So if you are watching, please be sure to comment and tell us who you are, what you're doing, what you're what you're working on, and any questions that you have for me, Dr. Bhatt, or the guest that we have. Dr. Bhatt, what's going on? You've been all over the place this week and last week.
It has been an exciting couple weeks. We had AI Med, which Anthony Chang hosted, and it was just wonderful. Really great leadership. Freddie and the team did a beautiful job. I'm going to get the numbers wrong, but somewhere around 600 or upwards people in the room there from all different industries who are interested in AI Med. So it was really a wonderful meeting. So, a lot more coming up as well. As we look to the future, the Consumer Technology Association is hosting a meeting tomorrow down in Washington, D.C. And we have cardiology conferences coming up this week and next. So it keeps going. But the good news is that the progress that we're seeing is now focused on implementation. It's taking the research and actually getting it to the bedside and getting it to the patient. And I think that's why I'm so excited for today's show, because Dr. Julian Goldman, who we have with us, is one of those people who's really able to take it to the bedside, and I can't even do it justice. I'm glad he has a couple slides to show what he's able to do. But I think we have a tight 30-minute schedule today, but it's going to be good. So I think instead of doing what's coming up, et cetera, we're going to go ahead and jump in. Does that sound okay, Jen?
That sounds okay. I do just want to say two things. One, I was on a Boston Globe panel earlier today, Health Equity and the Future of Virtual Care. It's really great. Boston Globe really did a fantastic job of organizing. Anna Kuchment is the Boston Globe medical and biotech editor who led it. Christina Severin was also on the panel. It was this morning. It was live and interactive, but it will be recorded. So take a look at that. And then you will see some postings that I'm also judging the M2D2 pitch off in the next week or so. So stay tuned. We are kind of having fun in summer and spinning down things, but we're still always out and about and love to hear from people. So Dr. Bhatt, you're going to introduce the fabulous Dr. Julian Goldman.
Introduce Dr. Goldman. So he is Medical Director of Biomedical Engineering for Mass General Brigham Health System and attending anesthesiologist at Mass General Hospital. And he's the founder and director of the program on medical device interoperability and cybersecurity. He founded that program in 2004 to promote innovation in patient safety and clinical care, which is really essential. He's board certified in anesthesiology and joined Harvard Medical School Department of Anesthesia at MGH in 2002. He's co-chaired the FCC mHealth Task Force. And importantly, he is really a leader in smart and autonomous medical systems. And that's the topic that we'll really discuss today is how do we create smart systems? How do we create autonomous systems? We've talked about closed loops before. What does that really mean? What does it look like? He's got some great slides.
We've talked about it. I don't believe in it.
It's going to be fantastic. We are so ready to see this. We'll also spend a little bit of time talking about the COVID-19 response teams and how things changed during COVID, because I think it's a great example of looking at how remote work became so essential and how that is still physically possible today. In fact, if I remember correctly, he first started this work with, was it Ebola? He first started this work during Ebola and then was able to really spin that up during COVID. The last thing that I'll say is he has won many awards, but one is the AAMI Foundation Institute for Technology in Healthcare Clinical Application Award and the University of Colorado Chancellor's Bridge to the Future Award. And I think that's just a great phrase to think about Dr. Julian Goldman and how he is, in fact, creating those bridges to what we think future states should look like. So with that, let's bring on Dr. Goldman. Perfect. Julian, thanks for being with us today. Great to see you.
Well, thank you very much. I appreciate the introduction, and I especially appreciate the opportunity to talk about a subject that is not only near and dear to my heart, but is becoming of increasing importance and awareness as we see what's really needed in healthcare. So I'm happy.
So maybe a place to start, just to, because the audience comes from varied backgrounds, is will you talk a little bit about kind of what the autonomous systems look like, what they mean, and if you need to use slides to kind of demonstrate that, I think that helped me when you and I were kind of talking previously. That would be great, because I'd love to kind of level set for people just a little bit in terms of what kind of things are we talking about, and especially from the perspective of you being an anesthesiologist and thinking about ventilators and other things like that. How can one think about things functioning on their own or functioning remotely? I think that's a little bit distant for people to think about.
Right. Well, I think we can take this down a notch by just talking about everyday high acuity healthcare that everyone who's in the audience, their family members have all experienced. And it points out the gaps that exist today in the most basic attempts at innovation in healthcare. So, for example, all of us have either had a family member in the hospital or had a loved one. We've been in the hospital, or we have a child in, let's say, the ICU or in a patient room, and an alarm beeps and beeps and beeps, and parents get worried. The infusion pump alarm is beeping, or the vital signs monitor is beeping, and everyone is worried. Patients are worried, family members are worried, and what happens? A nurse pokes his head in the door, takes a look at that, and oh, that thing always does that. Ignore it. And how many years has this been going on? And so, we all recognize that as patients, and you have to ask yourself, what is preventing, if the clinicians who are caring for the patients know that these are false alarms, erroneous, then why is it taking so long for us to make smarter systems that can tell the difference between a valid alarm and a false alarm? And now if you kind of extend that a little bit further and say, well, what if a patient is receiving a medication intravenously? And the nurse is supposed to be checking on the patient regularly and detecting a side effect of that medication. Now, that medication could be a narcotic to treat pain, and the side effect might be respiratory depression, which could lead to respiratory arrest, which could lead to worse things. And a nurse is supposed to check on that patient maybe regularly, or a pulse oximeter is used to detect if the oxygen saturation drops. But then if you take a step back and ask yourself, if we could build smarter environments, wouldn't we automatically stop the medication when an algorithm detects that the patient is getting into trouble? Not when the patient already has had an overdose and is in respiratory arrest, but when they start to become, when their respiration is too depressed or their oxygen level is starting to fall. So it's not just some crazy advanced notion of autonomous care in autonomous vehicles and drones and ambulances, which is part of the vision and has been for decades within within the Department of Defense for casualty evacuation. But, in much more mundane applications, it's about how do we build smarter and safer clinical environments that can take the knowledge from experts around the world and instantiate it at the bedside. Now, this was a crazy idea back when we started our work and started our program, which was an offshoot of the operating room of the future at Mass General Hospital, because that was before the iPhone. It was before smartphones. And we were asking the question, what is the approach we should use? What architecture should we use? How do you connect things together to build a smarter, safer environment that is intended from the ground up to be iterated, to be improved, to be extendable, to be open? And to allow the world to keep contributing, whether you're contributing new devices that are interoperable and can plug in, so you can, pick a more expensive sensor or a less expensive device, whatever you might need. But most importantly, to be able to ultimately add smart algorithms. And now, of course, we talk about AI and ML, every other word. And in my personal journey, I started working on AI and smart systems in the mid 90s for smart diagnostics. And I ran into these exact barriers where devices couldn't communicate. They're not interoperable. They're not designed to be controlled. So you may have a great algorithm that could stop that medication, but if you can't control the infusion pump to stop the medication, all you have is a science experiment. And so in identifying these gaps and needs around the complete healthcare sector, they affect standards, regulations, the FDA, medical device manufacturers, assumption of liability, ability to innovate. It's a full sector problem. And so that's what we started to work on in a more formal way when we founded our program in 2004 at MGH. So that's a little bit of that background. That's the driver. Yes. People shouldn't think, oh, autonomous, it's going to be like, 30 years from now, we'll have, smart automatic hospitals. It's more than that. And in a moment, we can look at examples that we've been working on right now to support the pandemic with remote control of ventilators and infusion pumps that becomes the foundation for more smart and autonomous care.
Fantastic. And Jen, I think you were showing a couple people that are new who've joined us today. If you're new and you're joining us, please let us know where you're coming from, what you're working on, even if it's not directly relevant to today's conversation. We're always excited to hear that, and so is our audience. Jen, is this a good time for us to maybe do a little show and tell with Julian?
Ooh, show and tell.
We love show and tell. All right, Julian, let's take a look at what you're actually doing.
Sorry, I see that I'm sharing. So it was So here's an example. This is a photo from the internet, some picture, which shows what's been happening during the pandemic. Think about as we hit the first surge, we didn't know how the disease was being transmitted, just how infectious it was, although clearly it's obviously infectious. And that raised a high level of concern about going in and out of patient rooms unnecessarily. It also caused the need to close the doors on patient rooms where maybe they weren't closed before. And because of that, it's so difficult to hear what's going on in the room. So infusion pumps were moved in the hallway with long extension tubing.
Oh, wow.
And in some places, ventilators were moved in the hallway, and they tried to use the longest tubing possible, which doesn't work very well with a ventilator. Yep. Now, the problem with going into a patient's room to make every adjustment to an infusion pump and to a ventilator is there's a host of issues. Number one, it can take 5, 10, 15 minutes to don the PPE to protect the caregiver. Also, we didn't have PPE, right? We were short on PPE. And so we consumed a lot of PPE just to go in and out of patient rooms. And then also, let's say the patient is having an urgent problem and you want to immediately change the dose of a medication or immediately increase the concentration of oxygen being delivered. There's going to be a delay until you can go into the room. So there are a lot of downsides, a lot of limitations to not being able to do anything unless you're physically in the room. Now, this was an idea that emerged during Ebola. And when Ebola hit the shores of the US in 2013, 2014, we were asked by a team at the White House
I don't remember Ebola hitting the shores of the US, but it did. Okay.
It did. It hit the shores.
I read the hot zone and I lived in fear of Ebola, but I didn't actually realize it hit the US.
Texas and southeast somewhere.
So the question came up, in the southeast then. Okay.
Can we leverage some of that technology, or what could we do? And so we were asked to pull a team together, and we pulled together about 19 different groups at that time, and we started to prototype what remote control could look like. And the important point here is that we invited the FDA as the first participant and asked if they would help, because manufacturers don't see a pathway to implementation if they think that the FDA will not be a partner. Absolutely. And so that happened in 2014. Now we fast forward to the pandemic, COVID pandemic, a public health emergency. And what the FDA did is early on in March, they published several immediate in effect guidance documents, which permitted manufacturers to add remote control to existing medical devices, ventilators, infusion pumps, and monitors.
So forward thinking. We love that, right?
It was fantastic.
Really, right? Yep. March 2020. Look at that date. That was really prompt movement.
And the key, I think, is by making the FDA a partner in innovation, they know what's coming, they're more comfortable, and they can help. And that's a key message that came out of this.
That's great.
So Medtronic manufactures the PB line of ventilators, formerly known as Puritan Bennett, and they modified the software based upon that FDA guidance to remotely control the PB 980 ventilator, which is in wide use. So in this picture, this is the ventilator. And this is a very nicely dressed mannequin in our lab in Cambridge. It's our test bed in Cambridge.
You put a tie on him, just like all of our patients.
Well, because of this presentation today, we thought it was right. And this is a mechanical lung, this system down here on the bed. And then this is a bunch of other computing stuff and webcams, and so that we could test their newly developed remote control for the ventilator. And so this screen is showing from my home at the time, the webcam showing that mannequin and the equipment, and I was able to control the ventilator from 8 miles away.
That's kind of insane.
That's amazing. There are people out there about to type in security questions, so I'm just going to prompt you as we talk about it. That would be
I think that's great. And part of the assessment that we performed in our lab initially in partnership with Medtronic and in plans for deployment at our hospital system, as well as around the country, we evaluated the security implications, cybersecurity exposure, because there were several different approaches to implementing this remote control. And and the way it was implemented, and that you're seeing it in this slide from my home, was over a dedicated VPN connection to the lab for secure connectivity. Okay. So that knowledge of the potential implementation approaches, different architectures, is a vital part of this. And I guess as an FYI for the audience, the FDA has a new draft medical device cybersecurity guidance that's out. And on the 14th of this month, they will be holding a public webinar to learn about their draft guidance. And you can find that on the FDA website by searching for cybersecurity.
That's great.
May as well mention that.
Yeah.
So also during the beginning of the pandemic, the Department of Defense, specifically TATRC, TATRC, the Army's Telemedicine and Advanced Technology Research Center, and ASPR, which is part of HHS, it's the Assistant Secretary for Preparedness and Response, stood up an initiative and funded a number of different performers, including us, our team at MGH and others, to address this big problem. If you look at this map, notice in amber or whatever color that you see, these are hospitals without ICU beds in the US. So the idea that we could suddenly take care of patients either during COVID or for other disasters and emergencies, it's really a challenge if you need intensivists. So as part of that portfolio, part of it was to leverage the work on remote control to be a foundation for autonomous systems. And so we worked with a number of manufacturers. These are different ventilators. This is a transport and emergency ventilator on the top left, and these are others from Nihon Kohden and Purt & Bennett, and a medical IoT platform from DocBox, which is a Massachusetts company, along with other products and fusion pumps and so forth. And we produced a demonstration, which people can watch on Vimeo, and there'll be a link here to all of these 6 different demonstrations. But now, while we're chatting, I'll show a demonstration. I'm just going to be selective about which one I'll show. I'm going to show a demonstration of a mannequin, i.e. a patient, in Toronto, about to be evacuated by ambulance. And the EMT who's about to evacuate that patient does not know how to operate that ventilator. So he consults a physician near Madigan Army Medical Center who uses a telemedicine application called OmniCure, which is part of this research portfolio. And they then use the DocBox IoT platform to control the ventilator all the way in Toronto. And this was all happened. It was all done live. And I'll show you a brief part of that video, being aware of the time constraints today.
At Thornhill Medical in Toronto.
And start the simulation. Go right ahead.
Hi, I'm Stephen Dane. I'm an EMT at Thornhill Medical in Toronto, Ontario, Canada. There was a tornado that ripped through the countryside just north of Toronto with a large number of casualties. Our ICUs are full, and we're just loading a patient into an ambulance to transport to the airport. All of a sudden, the patient's blood oxygen levels, or SpO2, are dropping. I need some expert help. I'm going to use the Netson OmniCure Telemedicine Virtual IC Critical.
Now I'm just going to jump forward.
You can see the is available.
And Dr. Dane, playing an EMT, Dane, is showing the app that's calling up Dr. Colombo, who's a real intensivist.
My application.
And I'm going to fast forward.
Also send each other and cybersecure compliance.
And
built into it. The patient's blood level, blood oxygen level has dropped to.
So just for the sake of time, Dr. Stephen Dane is telling Dr. Colombo the patient's in trouble and he's going to need some help to change the ventilator settings.
That sat dropping in the consult on the OmniCure app. Are you able to make the changes on the ventilator if I can make suggestions, or would you like me to make the changes for you?
Yeah, I'm not familiar with this device. It's not one I normally use. If you could make the changes, that would be great.
No worries. So I'm going to go ahead, folks, and share my screen. Date of birth, 13 November 1951.
That's correct.
Okay. So I am going to, after I verified the patient, I'm going to go into my apps and choose ventilator. And I can see that the FiO2 is at 30%. I'm going to go ahead and increase that to max for you. If you can just verify back on the vent, I see 75. We may have to readjust that probe. Is it in a good?
All right. So you can watch these, all these videos, but they tell the story all in real time. And so in the interest of time, I just going to point out, I'd like to point out that I want to show some of our team members that work in our MD-PNP program at MGH. So we have computer scientists, various engineers, other clinicians, and that's how we roll in doing this kind of work.
That's amazing, Dr. Goldman and Dr. Bhatt. We cannot hear you for some reason.
So if I can, I realize I may not have made a nice crisp connection. So remote control of a medical device means that you can work through its interface, its port, to control it. Once you can do that, you now set the stage for intelligent algorithms to be connected to multiple devices as part of an integrated clinical environment. And that enables the autonomous systems and the intelligence that we talked about before. So it's quite different than asking a manufacturer, please put this new algorithm into your single device. Because if you think about how clinicians operate, we never just look at one device. It's not enough information. So the only way to solve the problem of having smarter and safer systems is to integrate data in a patient network with high bandwidth, security and safety to do these kind of things. I'll also point out that preventable medical errors in hospitals are the third or fourth leading the cause of death in the United States still. Let's eliminate COVID from the equation for now. Mm-hmm. So preventable medical errors, these things can be prevented through better communication, autonomous systems, intelligence systems, and so forth. So we have an opportunity to save many tens of thousands, if not hundreds of thousands of lives a year if we have a healthcare ecosystem that will support these capabilities.
And I love the way that you point that out and what the video shows, right? Which is really that we're not replacing anybody. We are improving the level of care. We are making people who may not ordinarily do something more comfortable with that, with the supervision of someone who may be more well-versed in a certain type of acute care. And we are ensuring if we take oxygen up to max from 30%, that in fact the computer on the ventilator reflects the same thing, that did in fact happen. And so the number of checks and balances there still exist, but it's simply giving us an opportunity to take an expert's knowledge and give that to the areas where that expertise may not exist. And eventually, your concept is right, we could algorithmize some of that knowledge such that there is actually a little bit of propping up of all of the clinical expertise there by saying, remember, here's what the guidelines say, here's what we're reading and what you might want to do next. Here's how we're going to change things. Do you agree or not agree? And so I like that it's a collaborative experience between experts and those who are on the front line in the field, but also a collaboration with analytics and algorithms that help make care higher quality, that help make care safer, not because humans aren't doing their best, but because this level of data is a lot. And so, I think it's true.
And real-time, context-aware help. In one of our demonstrations, we showed how an algorithm can detect sudden cardiac arrest in the hospital and bring up an algorithm to help with the differential diagnosis and treatment without delay.
That's great.
These are things we should be doing,
Absolutely.
but the ecosystem doesn't yet support that easily.
This is a conversation. Oh, sorry, Jen, go ahead.
Okay, so that's a good, so that's my big question, is the ecosystem doesn't support it. So what did we learn during COVID in that we can remote control ventilators? I guess that question is, how often was that used? And they look way fancier. Like the interface looks easier to use now from when I trained 15 years ago. But so how much was that used? And then what does the ecosystem need to do to actually have a continuous loop? Though we made some interesting progress with the closed loop glucometer and insulin pump delivery.
Right. So I would look at all of these as steps towards learning how to do this safely. What all of these different projects do, they're helping to refine and define the requirements for medical devices to be controllable.
Sure.
And so we're working under this portfolio from Tatric, for example, to define requirements for ventilators to be controllable. What should be done to ensure they're safe? How could the manufacturer implement all of these things to ensure that the system will be safe and secure? And as far as the user interface, you pointed out a great thing. Once you have interoperability and the means to have a common user interface, you can. So one of the parts of this project is a single UI with 3 different ventilators. So you can, the same command will increase or change oxygen concentration on any of the connected ventilators with the same UI. So we're working on standardizing that as well. It's all part of this portfolio of work. There's a AAMI, which is a medical device standards organization that most people I think are familiar with. In AAMI, there's a interoperability working group where we're writing standards for remote control. So with a standard, it's much easier for a manufacturer to implement the capabilities and for anyone to assure that it's safe and for the FDA to clear the device as part of the regulatory process.
Well, this is wonderful because I think there are a lot of clinicians out there that are very interested in making things better, right? When you work on the front lines, you realize what are the things that aren't working. And so as Jen is shaking her head, no, we don't know about standards. Not everybody knows that AAMI exists. And so I think this is something for those of you, listening who are interested. There are many different groups out there that are working currently on standards for a variety of the different data points. Whether it's, AAMI, whether it's working with CTA, there are standards that are being developed, and it's important to have clinicians developing those standards alongside those groups or as part of those groups, because consumer technology or industry products, right, really do appreciate having clinical level guidance on what is safest, what is best, what is easiest to use. So I think that's really important. 2 other things. One thing came up at AI Med last week, and it addresses what you said, Jen, which is at what point, if you know that something that Dr. Goldman is working on with these groups is actually affording better, higher quality, safer care, at what point will that become the standard? And I will tell you, even though I was not one of the ones who raised my hand in the room when this question was asked, there were many who did. When I think Anthony Chang asked the question, how many people think in 2 years the use of AI in certain areas will be the default and recommended in order to ensure the safety of patients in certain situations, such that if you're not doing that and not implementing that, then you're not practicing at the highest standard. And I thought that felt very far off to get there, but I think there was a large proportion of the room that said once you show that the safety is that much better, safety will drive progress.
That is bold and a little scary. But I will say I was impressed by the new it is a closed loop. Am I not correct with the insulin pump and glucometer? So much that I had a diabetic come in and I was like, well, why are we going to dose insulin? Why don't we just turn on his pump? And he just turned on his pump. And I was like, we're good.
So interestingly, that was the original system. I think that was the original system. And Julian, correct me, where was it at MIT? There was a place where they were actually having cyber hackers try and get into a closed loop insulin pump to find all of the potential cybersecurity issues to then fix them. This was many years ago when this concept was first, being started. But I love that. First, the closed loop is great. And you're right. Why are we touching it? Let's just watch what it does and make sure we agree.
But
the second is you set up these systems, and then to go back to safety, you say it's scary. Your gut reaction was, oh, that's
It's
scary that that'll
scary.
happen. But to many people, the opposite is scary. Why would you rely on a single human making the right decision when a computer could tell you what the right decision is and the human could agree or disagree? And therefore, if they're tired at the end of a 36-hour shift,
Right.
their tiredness does not put your loved one at risk. And
200
so there are
to
there are two
400,000
camps.
200 to 400,000 deaths every year in the US due to preventable medical errors in hospitals. The way we're doing things today is not okay.
Yeah.
And you can crawl, walk, run, as people love to say. So Nihon Kohden, I didn't show this, Nihon Kohden has a remote control ventilator that's attached by a 10-meter cable. There's no network connectivity. It eliminates those concerns. And this has been widely used during the pandemic. So it doesn't have to be autonomous, and it doesn't have to be over a network, it doesn't have to be 100 miles away. And yet we can still have patient benefit and caregiver benefit as we evolve into more sophisticated systems.
Well, this is stimulating and really makes you see that the future is both here and can be extraordinarily helpful in delivering patient care. I see we're going a little over time. So Dr. Goldman, maybe thoughts from you about the audience who's listening right now from all different, walks of medical or even lay public life. How would you leave them from this conversation? What do you want them to recall, and what do you want them to look for moving forward?
I think that it's time for our friends, neighbors, colleagues, patients, peers, and everyone else to be very clear that the current state of healthcare technology and its inability to enable rapid innovation is not okay. That, we just looked at a small window of what could be possible to improve clinical care. And closed loop insulin control is a great example. Patients who use a closed loop system will never go back. They stop waking up at night with lows, right? Everything is better for them. And I have a family member who's been, uses one. I'm intimately familiar with it, and it's amazing. We use closed loop control in our lives every day. Our thermostat in our home, air conditioning or heat, it's closed loop control. And we have smarter cars. So we shouldn't be afraid of the technology. I think what the general public can do is make it clearer what problems they would like solved. And although we don't have the time at the moment, I could mention another project which we have been rolling out is a website called Good Ideas for Patient Safety. And the purpose of it is to collect the voice, let's say, of the customer. That's the patient or the clinician. It's the engineer who is a patient who says, I can't believe you're not fixing this problem. The parent who's frustrated at all the problems their child has with medical technology and inability to support optimal care. And so I think we'll find a way to put a link or to contact us. And as we roll this out, we will be inviting people to test it out and to just propose good ideas on how we could improve our healthcare ecosystem. Have a voice and make a difference. We need to change the way things are done today.
That's fantastic. I love incorporating, right, what everybody thinks we need to do rather than dictating it for other people.
Exactly.
Dr. Joe, your thoughts from today?
Absolutely. So really appreciate Dr. Goldman for joining us. I have been following your work for a long time. He didn't have that much of an opportunity to go through who he is, what he's done, because it's just so massive what he's done and the impact that he's had. So very delighted to have you here and always appreciate the work that you're doing, and super excited that everyone else is listening, are advocates of MedTech and the future of it. And I do like to underscore bringing in the patient and the clinician voice as the ultimate voice that should drive this. And I think there's a lot of things that we all want to see happen. So I am particularly interested in hearing the ideas that Dr. Goldman gets through this website, understanding how he's going to crowdsource them to float the best to the top, and better yet, how we're going to implement them.
Right.
And not in 20 years' time. I'm looking more for a 5-year horizon, Dr. Goldman.
I'm becoming more and more impatient. There's just no excuse anymore.
Agreed.
Yeah.
So Dr. Bhatt, any last words?
No, this is wonderful. Dr. Goldman, really have enjoyed your career. Dr. Joe is right. We weren't able to really go into the depth of what you've done, but to those of you who are out there and working hard on things where people say, well, I'm not sure. Well, that seems too far away. Well, that technology is not right. If you know that you are doing it for the right reasons, that it is making patient care better, improving safety, quality, decreasing burnout, increasing efficiency. Keep at it. Dr. Goldman stayed at it for 2+ decades to get here, but we are all behind you to get you there faster and still in a safe way to really improve patient care, because we're at a point where we can do that. We just have to all decide that we want to.
And a shorthand way to think about the future is using open health platforms to drive innovation, right? Just as we've done in other spaces for open platforms, these are open health platforms.
Oh, I
That's
love it.
wonderful. That's
Thank
wonderful.
you, everyone. Thank you,
Thank you
Dr.
to our
Goldman.
audience. Thank you,
Thank you
Dr.
very
Goldman.
much.
Thank you, Dr.
Appreciate it.
Joe.